Um, Soft tissue window.
Soft tissue. That was the first window you saw?
Yes, bone window, please. This tumor is cartilaginous in matlab chondroid. This lesion has chondroid matrix basically, which contain amorphous type of calcification, and it is just abutting the posterior rib, causing its subtle scalloping. So, in conclusion, it's a case of chondrosarcoma arising from the rib. I would refer this patient to the sarcoma MDT for the further biopsy of this patient and for the further management and involvement of the oncology in rest of the MDT.
Okay. Anything else that you want to comment on?
I can't see any definite extension into the spinal canal because I am expecting it can be neurofibroma or something schwannoma which is arising, but it does not contain usually the amorphous type of calcification. So it seems a cartilaginous tumor.
Okay, fine. So this is a young patient presenting with increasing pain in the knee.
Okay. This is the MRI knee T2 weighted images in which I can T1 weighted images in which I can appreciate soft tissue intensity, well-defined lobulated mass in the popliteal fossa. Could you show the image? Yes. No, it contains a few. It is low intensity lesions with internal areas of necrosis. There is no definite muscular infiltration seen. I would like to see the post-contrast images and T2 and stir-weighted images for the further evaluation of this lesion.
Okay, so I'm showing you now the T1 and stir. Yeah?
On the stir images, the lesion is bright. There is no surrounding structural infiltration, and the ligaments and the menisci in the knee appears normal. I would like to see the post-contrast window if available.
Yeah. So this is the post contrast.
There are multiple other lesions also appreciated along the posterior aspect of the thigh. And the lesion which I mentioned before is non-enhancing, while the rest of the lesions in the upper part shows marked post-contrast enhancement. These are inseparable from the muscles. So, in conclusion, keeping in view the multiplicity of the lesion, these can be multiple neurofibromas, and the other possibility, it can be the metastatic deposits. I would refer this patient to the sarcoma MDT for the biopsy of this the lesion and the confirmation of the diagnosis.
What metastatic deposits are you thinking about?
It's a less likely possibility, but keeping in with the imaging appearance and signal intensities, neurofibromas are my first possibility. Now sheath tumors.
Okay. Any other feature on that will, make you think it's neurofibroma?
It seems adjacent to to the nerve.
Okay.
And the signals basically low on T1 and bright on stir and post-contrast enhancements are in favor of neurofibromas.
Okay, fine. And but you saw this doesn't show any enhancement.
Yes. It can be the other possibility, it can be the sarcoma, and the others are the metastasis.
Okay. So, but if I if I show you this again in the T stir this, and then you have
The upper part lesions and the lower lesion have same signals in the star and T1 weighted images, but enhancement is different in
yeah,
these two images.
yeah. So would you be able to explain the non-enhancement of this lesion? Do you think there's any explanation for that? That's fine.
Sorry, I can't.
That's fine. All right. Okay, so this is a young patient who's presenting with severe knee pain.
This is the X-ray knee frontal projection of a young patient in which I can appreciate increased sclerosis and destruction in the lateral femoral condyle. The lesion has a wide zone of transition. There is an elevated periosteum which shows the Codman triangle, and there is cortical destruction along the lateral aspect, and there is associated soft tissue component. No extension into the joint cavity in this place. No evidence of calcifications, and the rest of the joint cavities and bones appears normal. So it's an aggressive lesion. Keeping in with the patient age and elevated periosteum, it's likely osteosarcoma. Less likely possibility of the Ewing sarcoma because it is mostly permeative and lucent in appearance. I would recommend MR limb with MR whole limb with contrast for the further evaluation and the local staging of this tumor.
Okay. In your normal practice, do you do it?
I would see the previous images and the contralateral limb.
Okay. So what imaging you want to do next?
MRI with contrast. On
Can you hear
star
me?
images, yes,
Yeah.
yes. On star images, there is an aggressive lesion in the right lateral femoral condyle with associated large soft tissue components, which is bright on star images, and there is edema signals in the adjacent muscles. There is no definite infiltration into the adjacent muscles. It is displacing the neurovascular bundle posteriorly. However, the flow wides are maintained. I would like to see contralateral limb is unremarkable. I would like to see the post-contrast images for further to further comment.
Okay, fine. I think the post-contrast images show a bit enhancement.
So it's likely a case of osteosarcoma. I would advise the CT chest for the local staging of the tumor. I would like to see the whole limb to see any skip lesions, and in the visualized bones, no skip lesion is seen. And I would advise the CT chest to rule out pulmonary metastasis. And I would refer this patient to the sarcoma MDT with involvement of the orthopedic surgeon and radiologist for the biopsy of this patient, and then involvement of the oncology for the further management of this patient.
Okay, thank you. So this is a patient who is known to have the given history is multicentric lobular carcinoma of the left breast and is
Okay.
now coming with some knee pain.
This is the X-ray knee frontal projection of an adult patient with well-defined intramedullary sclerotic lesion, which has ring and arc type of calcifications. It has narrow zone of transition, no associated endosteal scalloping, no associated periosteal reaction or any cortical destruction or soft tissue component, no involvement into the joint cavity, and the rest of the bones appears normal. So, keeping in with the imaging appearance, it seems a benign lesion, likely Enchondroma. I would like to compare the this radiograph with any prior, if available, to compare the images. And this lesion is not appears destructive, keeping in with the history of carcinoma. So it's likely an Enchondroma. I would further confirm these images on MRI writing post-contrast images.
There is no previous radiographs available.
Okay.
So we have the MR scan.
On the star images, this lesion is heterogeneous, mixed intensity, well-defined hypo and hyper-intense signals. Again, it shows no endosteal scalloping and aggressive features like there is no bone marrow edema, cortical destruction, or associated soft tissue component. So, in my opinion, it seems a benign, likely enchondroma.
Okay, fine. Do you want to see any other sequences, or are you happy with that?
I would like to see the post-contrast images if available.
So there was,
Some part,
yeah.
yeah, okay. On post-contrast images, some part of the lesion shows. I would like to see the pre and post both to confirm the enhancement.
Yeah, I mean, pre-contrast was exactly like this.
So it's no post-contrast enhancement, and the low intensity part of the lesion likely shows calcification, and the other part of the lesion is soft tissue intensity. So still, my in conclusion is it's an chondroma.
Okay, thank you. Okay, so this patient is coming with a painful right hip.
Okay, this is X-ray hip frontal projection, status post uh, total hip arthroplasty on the right side. There is no displacement, loosening, or fracture of the prosthesis. And rest of the bone shows degenerative changes. There is calcifications seen in the periarticular regions at the site of prosthesis, and there is seems associated soft tissue component, which can be effusion or any soft tissue thickening. I would like to see the post-contrast MRI. I would like to see the MR pelvis of this patient to further comment.
So at this point, what is your diagnosis and what you would like to do?
It can be heterotopic ossifications, but usually they are very well defined and circular in appearance and close to the joint. It seems an osteoid matrix which is developed around the joint, and it seems to be an aggressive process. So I would like to see MRI to further comment.
So what aggressive process are you thinking about?
There can be my development of the any sarcomatous lesion.
So do you think is it arising from the bone? or is it arising from the soft tissue, or?
It mostly in the soft tissues, basically soft tissue calcifications and opacity around the joint. Bones are unremarkable except the genetic changes.
Okay, so you think it is a soft tissue sarcoma that you're looking at?
Maybe, can be.
Okay, any other differential?
The other differential is post-processes heterotopic ossification.
Yeah, but then you dismiss that because you said it's not, you know, close to the bone.
Then the other possibility is myositis ossificans.
Okay, fine. And what features are you looking on the MR to help you?
I would like to see the soft tissue component. If it's present and there is associated enhancement, then it can be the neoplastic process.
Okay, so this is the T1.
This is the same patient.
Yes.
There is large soft tissue intense. This is the large soft tissue intensity
Hmm.
mass,
Hmm.
low intensity mass seen around the hip joint,
Sorry to
close to
burn
the
here.
eyelid,
20 minutes are gone.
Okay, thank you.
close to the right eyelid bone. I would like to see the coronal images, coronal and post contrast images if available.
So these are coronal images, and
On the star images, this mass is heterogeneous in appearance and marks susceptibility artifacts at this region due to the processes, which is slightly obscuring the details, but still there is heterogeneous lesion uh, in the proximity of the right hip joint. I would like to see the post-contrast images.
so post contrast doesn't show much enhancement.
Okay. There is associated effusion is also seen around the joint, and in conclusion, it seems an uh, aggressive type of process still.
What are you thinking? What is your?
It can be a development of sarcoma around the joint.
So where do you think the sarcoma is?
Sarcomas usually shows heterogeneous or any type of post-contrast enhancement, as this lesion is doesn't shows enhancement. So this feature is not in its favor, but the rest of the features like large soft tissue component. Uh, so still I suspect it can be. So I would recommend
So
biopsy of
I'll
this
go back to the
lesion.
plain film. The plain film has features there, and the MR has features. So which do you think is the tumor?
I think the large soft tissue component, uh, maybe
The large soft
it's
tissue component.
yes.
And so what are your thoughts about what you saw in the plain film?
Again, I'm suspected a large soft tissue component with calcifications on the plain film.
And can you see that large soft tissue component on the MR?
In the pelvic region, a hypointense lesion is present in the right hemipelvis.
Mm-hmm. Okay, so what's your final diagnosis?
It seems an aggressive process. I would recommend biopsy of this lesion for further.
Of which lesion?
Right pelvic cavity lesion.
Right pelvic cavity. So you mean this one
Yes,
here?
yes.
Okay. So this is a patient who's presenting with chest pain and swelling.
This is the X-ray chest frontal projection of a skeletally mature patient in which I can appreciate marked expansion of the right clavicle, mainly the middle and the medial aspect of the right clavicle. However, lateral aspect seems normal. There is sclerosis of this, and there is associated subtle periosteal reaction. Slight soft tissue component is also seen in the supraclavicular region on the right side as compared to the left. The contralateral clavicle is normal. Rest of the bones, soft tissues, lung, trachea, mediastinum, CP angles, and diaphragmatic contours are normal. So, in conclusion, an expansion of the right clavicle with sclerosis, it can be a case of chronic osteomyelitis of Gary. Uh, I would like to compare the prior images if available if the patient has any non-diagnosis previously. And the other, okay.
Yeah. There's no previous, but X-ray of the clavicle was performed then.
Okay. On this X-ray, there is a marked expansion, sclerosis, and lucensis is also appreciated along the lateral aspect with a subtle cortical erosion along the superior margins, and there is associated soft tissue component. So, in conclusion, it can be uh, it seems an aggressive process. It can be infectious process, and the other possibility is it can be the neoplastic etiology or metastasis. I would recommend CT chest with contrast for further evaluation if available.
Okay, so I think they have the. Yeah, they have the CT there. Jumping the thing, isn't it? Yeah, it's there. So I put in bone windows.
Yes, yes, sure. There is marked sclerosis of the clavicle.
Anything else?
With obliteration of the medullary cavity and few lucencies are also appreciated in this bone. There is no associated definite soft tissue component on this image, and there is no extension into the surrounding soft tissues or any bone or joint cavity. So, in conclusion, it seems a chronic osteomyelitis.
Chronic osteomyelitis. And do you think if we do the biopsy of this, it will grow anything?
I would correlate with the history of the patient. In case of chronic osteomyelitis, it should develop any chronic history or any previous imaging if available.
Yeah, I mean, there's
Yes.
no previous chest X-ray available. Anything else that you would think about?
Lab markers can also help.
Lab will help. Can you just tell me about two features of the chronic osteomyelitis?
In chronic osteomyelitis, there is increased sclerosis, which is called the involucrum, and then there is development of the dead bone in the dead bone, which is called the sequestration, and sometimes there are cloaca formation and sinus tract formations.
Okay, so you're talking about chronic osteomyelitis, yeah?
Yes.
Fine. So I think we are sort of time done. Is it Dr. Khan? Or
Yes, we have got 2 minutes left.
2 minutes left. Okay, fine. I think we may need to stop at that. Dr. Khan, do I give the feedback now or?
Yeah, you can. And, don't worry. So just give the feedback. And for the second candidate, we will start the time from zero.
Okay,
So take your time to give the feedback. They will love that.
okay, fine. Thank you. Thanks a lot. So, candidate one, well done. I think it's very difficult to, speak and think at the same time. So, well done for that. So, first case, I'm just going to go through. So, one of the things that examiners are looking for is to know whether you know the features that you're looking for. So, you said nerve-based, which is correct, but you didn't describe it. It has a typical, like what you call a comet tail appearance. Yeah, it's, you can see
Okay.
that it looks like it's along the nerve, and you can see it's connected. And I wasn't sure whether you appreciated it the first time when it went up. So just be a little bit careful not to just focus on that, but look at the other lesions as well. I think eventually saw it when we especially put the stir images, because you can see many more lesions there. And the other thing that examiners are also looking for is a little bit more a detail about the pathology itself. So yes, it could be neurofibromatosis. Other thing is schwannomatosis. Yeah, in this case it was schwannomatosis, but it's difficult to distinguish it very clearly just based on the imaging, but that can be a differential that you can offer. And the other thing is, when I asked you why is this not showing enhancement on the post-contrast scan when compared to the other ones, and the answer to that is because you can have what we call cystic degeneration. Yeah, so basically it's all become cyst now, so that's why it's not showing any enhancement. Cystic degeneration is actually a good sign. It's of chronicity, of benign nature. Yeah.
Okay.
So
Thanks.
I think those were the like the small teaching points that will help. But overall, you got the diagnosis and you said what it is, but you also need to say why it is that. So I think those will score you more points. Okay.
Okay.
So well done for that. Second case. I mean, this was your first case. So you did the chondrosarcoma. The only feedback on this would be, I want you to look at the CT again. So it is chondrosarcoma of the rib. So what is happening here?
Destruction of the pedicle.
Yeah, so that's why I was asking you. Anything else? I stopped at that image also, and I said, is there anything else you would like to, add to it? Yeah. So, and then if you go on the preset, see that? Can you see the
Yes.
tumor extending in?
To the
So
spinal
it
column.
was, yeah, it was a chondroid tumor, but they had to intervene when it started invading and into the spinal canal. So I think I have a post surgery, because they had to remove it because it started going into the canal. So it started invading down into the T3, T4, and if you we did then MR of the spine also, but you can pick it up on the first CT. So that's where it needs to be picked up to say that is it doing something more? It's going into the canal. Yeah.
Okay. Okay.
So when I was trying to ask you, it wasn't trying to take you away from the diagnosis, because you did say that it doesn't look like a tumor that's coming from the nerve, and therefore it's not a neurofibroma. But I wasn't trying to take you away from the chondrosarcoma. What I was trying to do was help you say that there is invasion
Okay.
into the canal. Yeah. Okay. So just
Okay.
keep an
Thanks.
eye. of the critical structures. So even, anteriorly, is it doing anything to the vessels there? Because those are the things that will harm the patient. Just having the tumor there, it's sitting there, it's not doing anything, that's fine. But it starts going into the vital structures, then that's where, the trouble comes. And because it started going there, they had to operate, because he will develop symptoms. He hadn't at this point, but then he will start developing symptoms. Yeah. So
Okay.
good. So that is chondrosarcoma of the rib. So then the next case. Okay, so at this point I asked you, what else will you do in your normal practice? Remember?
Yes. Yes.
What will you do? Now you don't have the Viva pressure. Tell me, what will you do?
We examine the patient.
Yeah, but you'll never, you know, just report it on one view, will you?
Yes. Yes, sure.
Okay, so you have to ask for the other view, because I need as examiner to see what is your normal practice. Like, will you, is it your normal practice to, look at all the views or ask for another view? If this is not there also, you tell the radiographer, please, can I have the lateral view? Can you, call the patient back, or, we need a lateral view. Yeah. Because it is
Okay.
important, because on one view, it's very difficult to, report. That's why we have, two views. And so please ask for the other view if it's not offered, because that shows that you are meticulous, you have a methodic way of approach, and you will, ask for the complete information for you to make a diagnosis. Yeah.
Okay.
So
Okay.
and this, you can see a big soft tissue component at the back here. Okay.
Yes.
And I think the MR was, let me just see which is this series here. Yeah, so this one actually shows. So this is a very nice example of, that the periosteum being raised, and all this is the soft tissue. So this is what you're seeing at the back, posterior aspect, where, the periosteum is raised. Yeah, and these are all the Sharpie's fibers which are holding the thing. So very nice example of an aggressive bony lesion with aggressive periosteal reaction around it. And yes, it was an osteosarcoma. Yeah. So you are scoring, but you can increase the scores by being a little bit more thorough and looking at the details.
Okay.
The next one. Yeah, this was very well done. So, Enchondroma. Again, I asked, is there anything else you want to do? You didn't ask for the second view. Okay, so
Okay.
you have to ask. So that is your like homework or something. Make a note. Ask for the second view. Yeah. Okay,
Yes,
so
sure.
that is again, very well done. And the only thing I would say is, have you heard of the term clump? It's
No.
chondroid lesion of unknown malignant potential. Yeah. So there is a criteria, and you measure it, and around the knee and proximal humerus, if it is above a certain, I think it's 4 centimeters the cutoff or something like that, there is a follow-up that you need to do, because if it starts growing, there is a chance that it could become a chondrosarcoma. But you were
Okay.
absolutely right in saying there's no endosteal scalloping, and there is no marrow edema around it. It has a very narrow zone of transition, and it has, like, speckled calcification within it. All those features are in Enchondroma. But if the size is more than 4 centimeters, I think it is 3-year follow-up with MR that you should do, and it's called BACTIP. It's from the Birmingham, the Royal Orthopedic Hospital, Birmingham, that they have set guidelines for when you will image a chondroid lesion, especially around the knee and proximal humerus.
Okay.
So that is your second homework, to look up the guidelines for that. Yeah.
Okay.
Okay. So but very well done on that. Okay. So the next one,
Thank you.
case 5. This was a tricky one. And again, you didn't ask me for another view, isn't it? because, you know, you have this view and it shows all this is happening here, and it shows, you know, this tumor coming up here, tumor like mass coming up here. Now, for this one, for everything else you said, can I look at the previous? You didn't ask for the previous on this one.
Yes, I should ask.
Okay, so what do you want to look at previous, and why do you want to look? So now, no Viva pressure, yeah? There is a processes. You said about heterotopic calcification, but I agree with you, it doesn't look like this at all. So I'm glad that you dismissed it, because, you know, it should be around, you know, either greater trochanter or, you know, where, you know, the insertions are, or, you know, in some places, but not like this round, like a shell around it. So we don't like that. But what else could it be? This is metal on metal. What else will happen? You have metal on metal. Over the time, it's increasing, you know, that calcification. And if I show you the here, so it's more like fluidy here. You know, all this calcification here is all like fluid. That's what you saw on the stir as well, right? So it's
Yes,
all like
yes,
fluid. And then you have, you know, these changes here that are also, see here, it is connected to the joint. See?
yes,
That's what
yes,
I was trying to show you that time. Like, you know, I was like, is there anything else? Is there anything else? Yeah. So because it's connected to the joint. So something that is arising around the prosthetic joint and forms a big soft tissue tumor-like mass. So what is it? See, can you see this?
yes,
Yeah. But it's not destroying anything. See, the bone is beautiful. Like, it's not doing anything to the
yes.
bone. Yeah. So it is what we call a pseudotumor. Yeah, so it is due
Okay,
to the metal reaction from the
okay,
processes. Okay, that's why it's called a pseudotumor, because it looks like a tumor, but it's not a tumor. Okay,
okay,
yeah, so that's why, I mean, the topic today is tumor and tumor mimics. So, but this is a very, you know, good mimic of what it can look like. So remember, for everybody who's, you know, looking, if there is processes and, you know, there is calcification there, or there's lucency in the bone, and, you know, the lucency can be really big, it can be big pseudotumor that you can have. And what I have seen is, it can either be completely intraosseous, or it will be like a lot of, you know, trochanteric bursitis and, you know, soft tissue mass. And if I show, I had this, isn't it, the T1? Yeah. So see, it is continuous with the joint itself. And if you see here, this is what you are seeing. This here, all this calcification.
yes,
Yes. Okay. So that's what you are seeing, and that's a typical pseudotumor appearance. At least this you can say, okay, this wasn't typical, Dr. Suresh, come on. But this is very typical. Okay, so
okay,
please remember pseudotumor, alval or metal on metal reaction, and it's a type 4 hypersensitivity reaction, because it's the soft tissue response to the fact that, you know, there's metal there and it's getting irritated. Okay,
okay, okay, thank you.
that is the and the last one. Okay, this one here. So you have acute osteomyelitis, then you have you know, chronic changes, like you describe the involucrum, you describe the sequestrum. Okay, but this is not that kind of osteomyelitis. It's what we call CRMO, chronic recurrent multifocal. It's called kind of osteomyelitis, but it is an inflammatory kind of chronic response. So if you do a biopsy, you will never grow bugs in this. Okay, multifocal, so they can be multiple sites as well. Clavicle is one of the commonest sites, spine is another one, long bones, and therefore we do sometimes, you know, whole body MR to look for the other regions, usually in children. Okay, if it is in adults, it's Sappho, you know, will be the equivalent in adults. So those are the features, and you described it nicely, saying that, you know, look, the rest of the bone is fine, it's expanded, it is increased sclerosis, and I think it has the periosteal reaction because it's a pathological fracture, and that's why the patient has presented. Because I said the patient presented with chest pain and swelling. That's why they presented with pain. Otherwise, they would have had it and they would have been there for some time, and you will never know unless it has like an acute or chronic, episode. And they treat it with low dose, antibiotics, because it's the inflammatory response of the antibiotics rather than the antibacterial feature of the antibiotic that is helpful. Okay, so it's CRMO, chronic recurrent multifocal osteomyelitis.
Okay.
Yeah. Okay, fine. So good cases, but that's like once you see the CRMO, once you see it, it's like it's like an Aunt Minnie. And when I did my fellowship in Stanmore, we looked at all clavicle cases. I think Dr. Saifuddin had like 200 clavicle cases, so I had to look at all of them and put them into categories and things like that. So there is one paper, I think, with Dr. Saifuddin on clavicular lesions. Have a look, because this is a typical presentation of CRMO. Yeah. Thank you. Thanks a lot.
Okay.
Well done.
Thank
Well
you so
done.
much. Thank you.
Priya, can I just get 2 minutes before we give before the next candidate? I've got an announcement to make.
Yeah.
Uh,
I will stop sharing.
No, you don't. You don't do anything. I'll just make an announcement. This is regarding the coming session, next week's session for the audience. We have designed a special session next time, which I wanted to announce so though you don't miss it. And this is about management. We get so many messages, particularly from overseas candidates, what to, because in FRCR, you are supposed to tell management in your long cases, etc., in your Viva, and a lot of questions can be about that. And this is how radiology is practiced in UK, because here it is what we call clinical radiology, and we lead it. So many people from overseas, they find it quite difficult what to do, how to do, what to say. So next session is a special session which Dr. Sakib Mughal, who is one of our faculty, you must have seen his sessions before. He is an IR radiologist and also has got a lot of interest in chest. So it is managing the management for the FRCR exam. Very special session. Do not miss it and pass this to others, because this is going to be something new. So he'll show you classical Viva cases, but go through the management bit of it. So this is what I wanted to announce. Thank you. And Priya, coming back to your, I think you were the principal editor for Dr. Asif Saifuddin's new edition, if I'm wrong. Correct me if I'm wrong.
For
For the MSK book.
Yeah, no. The MSK book, it was written when I was doing my fellowship, but no, I didn't participate in that. But I remember helping him, with few things.
Right. That was great. Okay, so candidate 2, are you with us?
Good evening, sir. Yes, I am here.
Okay.
So are we ready, Dr. Klam?
Good evening.
Yes, please. I am ready, and when you start, my timer will take your time. So 30 minutes here. I'll give you a warning after 20 minutes.
Okay, fine. So I will share my screen. So window. Share. Am I sharing the candidate 2? Can you see plain radiograph of the left knee?
Yes, ma'am. I can
Yeah.
see.
Okay, fine. So this patient is presenting with acute knee pain.
Okay, this is a frontal left knee radiograph of a major skeleton patient, in which I can appreciate that there's a lucent expansile lesion seen in the proximal aspect epiphysis and metaphyseal region of fibula. The lesion is well defined and it has a narrow zone of transition but it has a periosteal reaction adjacent to it, both along its medial aspect and the lateral aspect. And I can also appreciate that if I go along the lateral aspect, there's a bone break seen adjacent to it, which might be projectional, but because it's periosteal reaction, the periosteal reaction can be secondary to this pathological fracture. So I would like to know if there is any past radiograph available. I would also like to see it on any other view. Plus, the distal part of the femur is showing some degenerative type of changes, maybe due to disc atrophy. As I can appreciate that this is a skeleton who has just fused, but there are quite significant degenerative changes in the femoral side of the of this joint. So I would like to proceed with the lateral radiograph for this fibular lesion. I would like to know if there is history of any recent trauma or any trivial trauma. So it is likely a pathological fracture. So, ma'am, can I see the lateral
There
view?
is no history of trauma, and the patient is about 25 years old.
Okay, so on the lateral radiograph, I can appreciate again there is an expansile lesion. There is a subtle amount of bone break. I am not confident about it. And in this lateral, this is a horizontal shoot through radiograph. There is a pre-patellar soft tissue thickening. There are adjacent some calcific densities seen in the knee joint, in the Hoffa's fat pad. The tibial and femoral sides of the bone are quite degenerative. There are also some patellar there are also some patellar osteophytes in its lower extent. So I would like to check the record if the patient is the known case of any chronic kidney disease or any other disease which has led to this type of degenerative appearance. If not, then it can be due to a long-term disuse atrophy. So I will proceed next with the MRI for this patient to characterize the lesion further.
I mean, the patient had pain in both knees. So that is the right knee. So what you saw first was left knee, and this
Okay.
is the right knee.
So in this right knee radiograph frontal projection, I can appreciate that again there are lucencies seen in the distal end of the femur, and there are some mottled appearances. The medial part of the femoral cortex. Ma'am, if you can a little bit zoom it, it is a little bit irregular along the right medial side of the femur. It is quite irregular and shaggy type of borders. There is a periosteal elevation which is solid. The tibial side is relatively normal. I would like to check a record as this process is going on both sides, and it is predominantly affecting the femoral end. There is no widening of tibial notch. Intercondylar notch. So I would like to again check the record if their patient is known case of having any hemophilia or this is the right, and the right there are again some calcific densities in the soft tissues noted in the prepatellar in the superior along the superior patellar pole with a thickened superior patellar ligament. There are also in the along the posterior cortex there is a solid type of periosteal reaction. I would like to check the record if the patient is known case of any TB, it could be any hemophilic pseudotumor. There is the patella is quite closely abutting the femur, and there are patellofemoral joint space degenerative changes as well. So it can be due to renal failure, CPPD, hemophilia. So this is a long-term condition which is going on both sides. I suspect some systemic disease. And secondly, on the left side also there was acute fibular fracture. I suspect it is a GCT with pathological fracture.
Okay, so you are giving a differential diagnosis of GCT with fracture. And what is your second diagnosis?
Ma'am, my second diagnosis is that it can be an ABC with a fracture. Can I see any MRI if it is done for this patient?
No, we got the diagnosis with the plain film, so we didn't proceed to MR.
Okay. It is reaching, it is likely ABC. As it is the skeleton which has just fused, I will still consider the ABC as the first differential. Second likely possibility can be GCT. It usually reaches the epiphyseal subarticular surface. So I will keep that second in the differential. And a third possibility, less likely, can be a brown tumor, but that is why there should be a solitary brown tumor. So if the holes calcification and degenerative change are due to a chronic kidney disease, then this can be a brown tumor with fracture.
Okay, so if you're looking for brown tumor, you're looking for more lesions?
Yeah, ma'am.
Yeah. And you have looked at the other radiographs and you're happy with, what you have seen.
Ma'am, deep to the along the undersurface of the patella, there is a lucent lesion as well. But the density of these two are different.
Okay, so we'll
Yes.
have GCT, and then you have the second one you gave was ABC, and the third one you gave was brown tumor
Yes, ma'am. Due to
or
hyperparathyroidism secondary.
chronic. Okay, so this is a very young 10-year-old with a limp in the right side.
Okay, this is the X-ray pelvis frontal projection of a patient who has presented with a limp on the right side. I can appreciate that there is the line of Klein is intersecting. Line of Klein is not intersecting the distal 1/5 of the epiphysis on the right side. Also, the contralateral side looks relatively the same. Is there any frog leg view available for this patient?
There is no frog leg view, and the frog leg view didn't add also anything if they did it.
Okay, so if the patient has presented acutely, I would, as the soft tissue planes on the right side are somewhat blurry and somewhat hazy on the right side. Plus the joint space a little bit bulky and widened between the acetabulum and the epiphyseal head. So I would like to know the history if the patient has presented acutely with some fever and redness.
No fever, intense pain.
Intense pain.
So pain causing limp.
Pain causing limp.
What would you like?
Ma'am, I would like to do an ultrasound this patient.
Okay, so ultrasound showed, small effusion.
Okay, then I will proceed with MRI.
Okay. So I'll show you first the stir images, yeah?
Yes, on the stir images, I can appreciate that there is a area of marrow edema seen in the metaphyseal region of the right hip. Also, I can appreciate that in the region of lesser trochanter, there are different signals. There are area of hyperintensity which are noted. There is no evidence of any soft tissue mass lesion. There is a hypointensity noted in the projecting from the lesser trochanter towards the superior side, and there's also a lucent area which is seen within this deep part of the marrow edema. Yes, here. So I would like to see it on the axial first. Axial, same sequence. So in this axial images, as I scroll, I can appreciate that there are normal there is a lesion which is a very narrow zone of transition. There is intense marrow edema, and there is a small focus of hypointensity which is seen projecting from the cortex. And as I suspect that it is a very typical location of osteoid osteoma, and plus there is a focus of hypointensity. It could be osteoid osteoma, so I would like to do a CT. Also, I do not appreciate any mass lesion associated with this edema type changes on the MRI. Ma'am, there is an increased amount of sclerosis in the same region. I would like to turn it into a bone window. In the bone window, I would like to scroll it, and
It jumps a little bit, but it's coming there. Yeah.
so there is an area of sclerosis with internal lucent area. It is, I cannot appreciate any further density within it, which is typically described for osteoid osteoma, but this sclerosis with corresponding marrow edema, without any soft tissue mass lesion, without any periosteal reaction, underlying bone break, any other scalloping, it is very typical for osteoid osteoma. I would like to refer this patient for MDT discussion. How to proceed it with RFA? These cases usually pain subside with the salicylates, but which approach to take to avoid the neurovascular bundle for RFA ablation? This I would like to refer for MDT discussion, and patient should be immediately informed for further putting on the pain meds.
Okay. So this patient, oh no. So this patient presented with pain down the arm.
Okay. This is X-ray chest frontal projection of a patient who presented with pain in arm. I can appreciate that there is an increased amount of soft tissue density which is noted along the left apical region. Also, the adjacent part of the clavicle, superior part of the clavicle, is showing a blurry zone. Yes, ma'am, if you can change the window as well, a little bit change of window. I would like to see the underlying rib status. Second rib is definitely eroded, and the underlying vertebrae is also showing some affection. The second thoracic vertebrae, which I can appreciate. Rest of the ribs, which I can appreciate in this imaging, is normal. There is no evidence of any other clavicular lesion. So I suspect that in this location, it is extending above the clavicle. So it is definitely a Pancoast tumor, and its location is causing the erosion effect on the nerve and break. I would like to see its communication for underlying the cord, underlying neurovascular bundle, plus the soft tissue density of the neck on both sides are also different. So I will proceed with cervical neck MRI with contrast. These are the T2 weighted sagittal images of the same patient, in which I can appreciate that there's a ISO 2 hyperintense well-defined mass lesion is noted in the left apical region. The underlying bone are showing no scalloping, but there are marrow changes in two of the adjacent vertebral bodies. Also, I would like to see the underlying status of it is. I would like to see the scalene muscle and the nerves. Ma'am, can you please give me a coronal view to see the.
There's no coronal view, but I can give you a axial.
Okay, on this axial view, there was a left-sided lesion, and there is, I would like to see its extension into the spine. There is erosion of the adjacent vertebral laminae and pedicles, and there is a prevertebral, paravertebral soft tissue mass.
Mhm.
And yes, this is it. It is crossing midline to some extent. There is widening of the foramina. And ma'am, this is the stir image. Can I see the post contrast enhanced image as well?
All this shows enhancement.
Okay, so this is a Pancoast tumor, which is causing involvement of the underlying vertebrae, is eroding the posterior elements, and is entering into the intervertebral foramen, and is involving the nerve roots. It is also causing erosion of the adjacent clavicle and vertebrae. I would like to see in my routine practice the flow voids of the adjacent vessels. It is encasing one or two of the arteries. So in my routine practice, I would like to see its relation with the vessels, and uh, I will urgently communicate the findings because it can lead to vertebral collapse, it can lead to cord involvement, and because currently at this status it is only involving the neural foramina root, but it can involve cord further. So it should be ideally communicated emergency finding and further reference in the MDT for management, how to proceed.
Is there anything
Also,
else?
I
Yeah.
for looking. For surgical management, it should be surgically excised.
Okay, so you're done a chest X-ray. You're done a spine MR.
Hmm.
Is that what you would do for if you
Hmm.
see something on the chest X-ray?
Ma'am, I would like to see a CT chest with contrast as well. So this is the CT chest with contrast of the same patient. And I can appreciate that the same mass lesion, it is exerting significant mass effect on the trachea. Trachea is pushed towards the right side. There is encasement of the vessels. Ma'am, can you please scroll a little bit at this point? The normal density of the vessels is maintained, but there is loss of the fat planes between the left common carotid artery, particularly. And there is, I would also like to see the esophagus is normal, aorta is normal, superior vena cava is not occluded, and the right common carotid is also normal. So there is encasement particularly of the left common carotid artery. I would also like to see the rest of the, in my routine practice, I would like to turn into a bone window, see rest of the waves on the CT. I would also like to see on the lung parenchymal window to see any lung nodules.
Okay, fine. So I'm moving on to the next case. So this is a young patient again, presenting with fullness in the shoulder.
Okay. This is X-ray right shoulder of an immature skeleton. I can appreciate that there are some motile lucencies are seen along the epiphyseal region of the right humerus. There is some periosteal reaction which is also seen along both sides of the both cortices. Ma'am, can you please change window a little bit? I suspect that there is some periosteal reaction along the medial side, yes. And there is also, if I compare with the lower medullary signal, the upper signals are a bit more
Excuse me, 20
hyperdense.
minutes, 20 minutes have gone. Thank you.
Thank you.
So I would like to proceed this with the MRI shoulder with contrast, as I suspect there are some motile lucencies. and the periosteal direction. Rest their scapula is normal, clavicle is normal, visualized part of the ribs are normal. There is no soft tissue density lesion is seen. There is some fuzzy fat planes noted along the axillary region. So I would like to do an MRI.
So what is your differential at this point?
Ma'am, at this point, it can be, as it is a pediatric, still a pediatric age group patient, it looks like an aggressive lesion. It could be chronic osteomyelitis, a Ewing sarcoma, it can be a leukemia, but I'm thinking in lines of some aggressive process. So I would like to proceed with MRI.
So you think there is a periosteal reaction, and that is the aggressive feature that you're seeing on this?
Then there's some fuzzy outline along the medial cortical margin, and also the density of the cortex, density of the medullary cavity was different along the, yes. So as it is a pediatric age group patient, and plus I also appreciate that there is some prominent notch along the inferior scapular margin, but that can be due to any spur. So I suspect that it can be an aggressive process.
Okay, so what do you want to do next?
It can be a chronic osteomyelitis as well.
Okay, so I have chronic osteomyelitis leukemia, yeah, as your differential.
Sorry,
So
ma'am.
what do you want to do next?
What I'm going to do next, ma'am, I'm going to do an MRI shoulder of this patient with contrast. And in this MRI shoulder, I can appreciate that there is a well-defined lucent hypointense lesion on this stir imaging, and there is an intense edema which is surrounding all this. And most likely the fuzzy fat planes which I was seeing on the shoulder radiograph was due to this edematous changes, and the primary lesion is in the epiphysis. It is very well defined. It has a narrow zone of transition and some internal hyper intense foci. It has some foci of sclerosis within it as well. It is located in the epiphysis. There is no adjacent bone break, any scalloping. There are some changes of disuse atrophy, and all the changes which I was seeing on this medullary cavity were probably due to the intense marrow edema and diffuse atrophy and some synovial hypertrophy and reactionary soft tissue changes. So this is likely a very typical appearance of a chondroblastoma, and patient must be in an intense pain. In my routine practice, I would like to see it on other axial coronal sagittal planes, post-contrast imaging as well. So I will like to communicate the findings to the orthopedic department for further management, because these are quite painful conditions, and treatment should be planned accordingly.
Okay, I'll hurry you up because we need to see two more cases. Okay.
Okay.
So the next one is a patient presenting with shortness of breath and heaviness in the chest.
Okay. This is exogenous frontal projection of a patient who presented with heaviness and shortness of breath. I can appreciate that there is increased cardiac contour, which is visible. I would like to see the clavicle, the both humeral heads. Both humeral heads are showing there is some subchondral lucency seen along the right shoulder, and I
think
would
that's
like to
normal.
check. That's what?
That's normal.
So that's likely projectional. So the finding which I can appreciate is that there is an acute large cardiomegaly. There is normal gastric bubble appreciated, and there is I would like to see the clavicles. Clavicles are normal. There is Ma'am, can I please again know the history patient presented with?
Shortness of breath and heaviness in the chest.
Okay, so ma'am, can you please change window a little bit? I appreciate some retrocardiac opacity, which is there. There are some retrocardiac opacity is seen, particularly along the right right paravertebral region. Can I see any other view, any lateral view available?
No, there's just view available. They didn't do lateral.
Is the patient known case of any disease like sickle cell disease?
No.
No.
What do you want to do next?
Ma'am, I want to do CT with contrast.
Okay.
Okay, so these are the CT abdomen and chest with contrast imaging, in which I can appreciate that there is a well-defined hyperdense area which is seen encircling the heart. In my routine practice, I would like to measure its density. It is appearing to encircle it, and it is also exerting significant mass effect on the right cardiac chambers, and it looks more like a soft tissue density lesion rather in the plain chest radiograph, I was suspecting some bottle-shaped heart. Might be due to pericardial effusion, but this looks more like a soft tissue density of mass lesion, which is encircling the heart. It could be I would first like to see whole of the images. It is involving one of the chambers. There is reflux of contrast within the IVC, and there is significant yes, there is reflex of contrast within the IVC and in the not in the hepatic veins. There is ma'am, can you trace it a little bit more? Eh, that hyperdense lesion which is seen, it can be a lymphoma or a sarcoma. Ma'am, can I see the coronal images?
I don't have the coronal images. I have an MR, cardiac MR.
Okay, so these are the cardiac MRI images. These are the T1 weighted MRI images, in which there is a very well defined there is a lesion seen within the lateral margin of the heart border, and it is enhancing. Its wall are
Okay, so
enhancing.
what's your diagnosis?
Sorry, ma'am.
What's your diagnosis?
Ma'am, my diagnosis is that it is an enhancing soft tissue density mass lesion along the right atrial wall, and there is a secondary involvement of the cardiac chamber, which is resulting in a significant secondary
No, what's your
constrictive type of
diagnosis?
changes.
So what do you think it is?
It is all resulting in constrictive cardiomyopathy.
Okay, so I need to show the last case. We need to see the case. That's why, yeah. Okay, fine. So the last case is, yeah. So what can you? This patient is presenting with again knee pain and actually a swelling in the lower thigh.
Okay, so this is a frontal knee radiograph, left knee of a patient, in which I can appreciate multiple exostosis, which are originating from the epiphyseal, diaphyseal region of all the visualized bones. They are directing away from the joint. I can appreciate that most of them are showing a normal outline, but the one along the left medial femoral margin is a bit blurry and hazy. Ma'am, can I see any other projection, lateral view available? In the lateral, ma'am, can you please change window a little bit? Okay. So I forgot where that lesion was. I think there is an undulating type of posterior. There are multiple lesions which are seen along the posterior cortex, and the underlying bone is underlying femur. It is quite, it is
Okay,
normal. There is
again,
no,
see that again. Yeah.
ma'am, this, I would like to take the history, if there is history of any trauma. I suspect some break in continuity along the this biggest lesion.
No, no history of trauma.
No history of trauma. Then I will proceed as there is pain. So I will proceed with MRI because there is a propensity for them for malignant transformation. I would also like to correlate with the past X-rays to see any interval change in size. As I suspected that there is some blurry outline of that largest lesion which was along the medial cortex. So I will proceed with MRI with just this fine.
So what are you worried about?
Sarcomatous transformation.
So what will you look for?
I would look for a cartilaginous gap. More than 1.5 centimeter or 2 centimeter is abnormal.
Okay, fine. I think the time is done. Dr. Khan, am I right?
Yes, please.
Yeah. Sorry, I had to hurry you because that's what will happen in the exam also. If you have to see 6 cases, so they will hurry you up so that, you have seen all the 6 cases. Yeah. Fine. So candidate 2, well done. Again, I don't think it's an easy task to think on your feet and keep talking at the same time, but that's what we need to do in the exam. So I'll go through the cases now. So this is last case. Yes, it was because of time pressure. I was going to show you actually this case where it shows very subtle, changes of the diaphyseal ectasis. Yeah. And then ask, do you want to see anything else? If you do get, there are multiple lesions, then show you the second case. But because of time, I showed you the first. But in the exam, they will have a set way. And if that's the case, that's what they will show you. Because they have to show that for everybody, it will be the same. Yeah. So just to make sure that, that's very easy to diagnose. But sometimes when you have the cases, and this patient was presenting with shoulder pain, and, they have these diaphyseal ectasis because they have multiple exostosis, and they went on to have a MR, but thankfully the MR didn't show a big cartilaginous cap. It was fine. You can see there, the cap is not raised. The things that they would like to know is what are the causes of pain in diaphyseal ectasis. So can you tell me what are the causes?
Yes, ma'am. Usually it is after the trauma or if they are impinging on a nearby nerve root. So
Yes.
that is also a relative indication for surgery if they are impinging quite closely because that will lead to denervation, atrophy of the adjacent supplying muscles.
Yeah. So that's what I would like to hear when I said, the patient is presenting with thigh pain. Yeah. So things you would like, yes, you would want to do an MR, but always say what you're looking at the MR. So could it be, any muscles or any tendons, in that region are stretched out across. And so it can be mechanical, it can be due to the neurovascular bundle, it can be due to fracture, or it can be due to sarcomatous change. What is the percentage, do you know, sarcomatous change in
It's
Jimmy?
2 to 3%.
It's as high as 10% in HME, like because there's increased thing of sarcomatous chondrosarcoma in patients with diaphyseal ectasis. And so we had recently one case where there's a big a lesion in the iliac blade, and the patient can feel. Again, if it's in the pelvis, you can't feel it. So I was looking for what the guidelines are, to follow it up, because pelvic chondrosarcoma is higher percentage, and malignant transformation in more proximal lesions is higher, even in diaphyseal ectasis. So just there is, much higher than solitary tumors. So this one, Why didn't you give me chondroblastoma as a differential on the plain film?
Ma'am, I think I didn't got the idea. I was all focused on the change in the change in the density of the medullary cavity, so I was worried
Okay.
about that.
Okay, fine. Because I was like, why is she not talking about, this, and why is she not taking, okay, pediatric patient, epiphyseal lesion, what's the most commonest? Chondroblastoma. Yeah?
Yeah.
Okay. So, I mean, because if you think about it, there's not many differentials. So if you want to know what are the epiphyseal lesions, all the epiphyseal lesions in pediatric population, it's chondroblastoma. That's it. Because
Yeah.
you can get infection, very rare. It's more within metaphysis that you get the infections. I mean, being epiphyseal is very rare. The other one is GCT, but that is in adult patient, not in pediatric. And the other one is subchondral cyst, which is again in adult patient, not in pediatric. Yeah, a geode. Okay, so that's the only one in pediatric patient, and you picked it up very nicely on the MR. I mean, you immediately said, "Oh yeah, it's chondrite, tissue. There's calcifications there," and two things. It can have intense marrow which you're right. It can also have intense big effusion, you know and so people mistake it for infection, thinking, oh, effusion, marrow edema, it must be infection. But chondroblastoma can have that kind of reaction. So well done on the MR. I mean, very, very well done, because many people have misinterpreted this. So but I would say that you could have picked it up on the plain film as well, but I don't think you'll drop marks, because you said you do this next, and you will give the thing, so that's fine. What is the next case was yeah, this one, pericardial effusion. Yeah, so you went with pericardial effusion, you went here, and then you started saying this is an encasing mass. I was like, no, 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 it's not. So I was trying to help, saying that uh, yes, focus on the mass, like, rather than this whole thing. And then the this was an angiosarcoma of cardiac angiosarcoma. So you may not get that, but that's fine. The main thing is to see that there's pericardial effusion, and this is like a necrotic tumor because there's enhancement, and it's a post-contrast scan. So part of it is not enhancing at all. So heterogeneous soft tissue mass, internal necrosis. It's arising from right atrial appendage, and it was presenting with shortness of breath, heaviness, because of the pericardial effusion, which was malignant pericardial effusion. Like you get in lung tumors, you get malignant pleural effusion. You can get malignant pericardial effusion. Yeah. So it was just in keeping with the theme of sarcomas. So I thought, okay, we'll include a angiosarcoma as well. Now you're seeing it, you know how it can look and what it will have features. What's the other one? Yeah, this one, chest X-ray. Don't forget, like, because the MR came up, it won't come up on the thing. I had to go for the chest X-ray, but I went for the MR. So once you do the chest X-ray, you will usually do the CT. So follow that path, like because you need to see whether there are other lesions, and then you say, because of what you can see on the CT, and the patient is presenting with pain in the hand, and is it left hand? You can confirm that left upper limb, and then you go for that. The other feature that I was waiting for you to pick up is the tracheal deviation. Yeah.
Okay.
So on the CT you picked it up, but very nice tracheal deviation, big mass. You did pick up that there is rib destruction, but you can also see that the spinous transverse processes are hazy, not well defined, and it's gone into the canal, as you could see it in the MR. Yeah. So good on the chest X-ray to pick up, that it's happening Pancoast tumor, but you gain more marks if you are able to pick up other features that are there as well. Yeah. So just tips to pick up more points there. Okay.
Okay.
So good on that one. Um, so this one, very good. So if plain film is normal, yes, you will do ultrasound. It shows what you do, and that's the routine practice. In young patient, limp, that's what you do. And then if the ultrasound just shows, a small effusion, it shows effusion, then you're on to, the MR to see what it is, and that's an osteoma. Very nice nidus that was shown. And the nidus doesn't have to have a focus calcification always. Okay, so I think that's what you were saying. I don't know why I can't see it, right? You're saying, I see the nidus, but I can see the hypodensity, but I can't see the thing. It needn't have that all the time. The first case. So what is happening here? What is this?
Ma'am, I still am not able to figure out that there is these type of degenerative changes shouldn't be there in this age. There's soft tissue calcification
Is it
and
degenerative change?
yeah,
Is it a degenerative change, or is it like a brown tumor that you're looking?
ma'am, it is eccentric.
But you won't get. You're right. It's not like a subchondral cyst that you have there. Yeah, and you're looking at it tangentially. Yeah.
Okay.
So it's a brown tumor in the distal femur, and the same here. Look.
Okay.
Yeah. So, and on this you can see the thing.
Yeah, one here
Yeah.
as well.
Okay. And the more you look, the more you can, because you just wanted one more tumor somewhere, and you would have been happy to call it brown tumor, but actually they're there, and that's what I was trying to show. And so this was, and I said it was a young patient to take you away from the fact that you are trying to say it is degenerative changes. And actually what is happening, it's resorption of the bone in all those surfaces, and that's what is causing its resorption of the bone. There's a little bit of calcification. So this was primary hyperparathyroidism.
Okay.
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 Yeah. So subperiosteal resorption, medial epiphysis. If you see here, look at that, beautiful. Sometimes examiners are very proud of their some of their cases. Look at that. It's a very nice case of subperiosteal resorption. Yeah. So yeah, primary parathyroidism. So you were getting there. You're sort of getting there, but you were telling me GCT, ABC. I was saying, no, don't focus only on that. Look at everything. You did get that the mineralization is not right. It's very coarse, and but you're not putting it together. So that's why I was saying, what is your final diagnosis? Like, what is one diagnosis? Or I sort of loaded it and asked, is it two diagnoses you're thinking about, hoping that you'll say no, one diagnosis. Like, so those are the features that you're looking for. I think you picked it up. The thing was trying to put it together. Yeah.
Yeah, I put it as a third differential.
Yeah. So well done. So I think that's all the cases that you had. And like I said, because the format is like you have to see the 6 cases, don't be put off if the examiner is trying to hurry you. Be mindful and try and keep the pace up, because you have to see all 6 cases. Yeah.
Okay.
Well done.
Thank you, ma'am. Thank you, ma'am. Thank you, sir.
Candidate 3, are you
Go for
with
the
us?
third candidate, or it's 8:30. I'm very aware of that.
No, don't worry. This is gold for them. Don't worry. So please continue. Candidate 3, are you with us?
Yes, sir.
So, Priya, full 30-minute Viva, and don't worry about time, because this kind of teaching, they need it and they don't get it. So time is not an issue. Over to you.
Okay, fine. So I'll just set it up now. case. Window. Load. Okay, fine. So I'm ready. So that's my sharing. Window. Share. Okay, candidate 3, are you ready? Can you see plain radiograph of the right knee?
Yes. Yes, good evening. I'm candidate 3. Yes, I
Yes.
can see X-ray.
Yeah. Okay, fine. So we start, your time starts now. So this patient was presenting with, again, knee pain. He's a 15-year-old.
I'm presented with frontal radiograph of right knee, and there is the most remarkable finding I can appreciate is that there is bulbous medial right femoral medial condyle, and the bone density is preserved. The medial and lateral joint compartment, tibiofibular joint compartment is normal. I can also appreciate. I would like to change the window as I'm suspecting some lucency in the metadiaphyseal region, which seems like projectional. I would like to see the lateral view of the patient. I can also appreciate a similar lucency in the medial metaphysis of the right femur along the femoral condyle as well. No associated periosteal reaction, no associated pathological fracture. So yes, I can see that there is lucency noted along the posterior aspect of the medial, posteromedial part of the right medial femoral condyle. As this is having narrow zone of transition, so I'm suspecting benign pathology. The differentials in this finding can be as the DNA is lacking any sclerosis. So, and multiplicity of the lesion, I will keep the brown tumor as my first differential, and no erosive bone changes are seen. So I would like to confirm these findings by asking the history if the patient is having bone pain in any other joint, as the patient is young, and I will further proceed with MRI of the knee to confirm my findings.
So what is your differential? You said, I mean, you didn't give a differential. You said brown tumor.
Yes, and the second possibility, which is less likely, and keeping the multiplicity with narrow zone of transition is less likely, but I'm thinking of NOF as well, non-ossifying fibroma.
Non-ossifying fibroma. Okay, fine.
Yes.
And you want to do an MR scan?
Yes, for this patient. So this is the stir MR images of the same patient. And I can see the two lesions, which I already described on the X-ray, and these are heterogeneously hyperintense with lobulated margins noted in the lower medial condyle of the right femur, and having narrow zone of transition without any periosteal reaction or cortical break. So I will stick with the diagnosis of non-ossifying fibroma as my first differential. So brown tumor is not a diagnosis in this case. I will further, there is third lesion also noted along the medial diaphysis of the femur as well. So I would like to take if there is history of any skin lesions, as I cannot appreciate any skin lesion on this MR. These are associated with neurofibromatosis, multiple non-ossifying fibromas, and I will inform my findings to the referring clinician, and I will keep the patient on follow-up and compare if there is any previous imaging is available, and we'll refer the case to the orthopedic if there is any symptom.
The next patient presented with a lump in the back of the neck.
Okay. So
And
I'm provided with the, yes.
yeah, and it's been
So,
present. I mean, they are about 40-year-old, and it's been present for about 2 years.
okay, I am provided with the T1 MR images of the patient in which a fat attenuation lesion is noted on the back of the neck and the lower cervical spine, which is overlying the muscles. I can see that there is mild pressure over the underlying muscles. There is no skin or subcutaneous tissue infiltration. There is differential density within the lesion as well. I would like to see this on post-contrast images to rule out any enhancement. As the lesion borders are sharp, so this is likely a benign skin lesion. Beside this, moderate degenerative changes are also noted in the cervical spine as well. So I would like to see the post-contrast axial MR image of this patient to further comment on enhancement.
Okay. I mean, I have a stir image for the same patient,
Yes, on
and
star
this
image,
one did not show any enhancement. It was, just the same.
okay, on star images, the lesion shows fat suppression, and the lesion which was hypo on T1 is being bright on the T2 star images. So this is in keeping with the benign, well circumscribed lesion. I would put the differential of atypical lipoma. Um, Second possible differential is lipoma with some myxoid component, which is being high on stir. No further lesion is noted in the vicinity. I will inform the findings to the referring clinician and will refer the case to the surgeon. If there are any local symptoms or this lipoma is causing some pressure symptoms, then they will manage the patient accordingly. And there are multiple compressive disc bulges are also noted along the lower cervical spine, which are indenting the thecal cycle, having mild compression on the cervical cord. No hyperintense signals are noted within the cord, and rest of the brain structures and bones are apparent unremarkable.
Fine. And the lump itself, would you say it's a simple fatty lump? Or?
No, madam, it containing the some myxoid component, or it is having some different component. I am right now not recalling the name. Lipoma, maybe a myelolipoma or lipomyxoid, some benign lesion. I don't remember right now. I cannot
Okay.
recall.
So do you think this is benign or this is malignant?
As the lesion is showing no enhancement, so this is benign. This is most likely a benign. And it is over the period of 2 years, so this is also in keeping with the benign lesion.
So this patient is presenting with low back pain.
I'm provided with a frontal radiograph of the lumbar spine, including bilateral sacroiliac joint. I would like to zoom the image a little bit to further comment on the bones. Uh, Faint sclerosis is noted along both medial femoral heads. However, no definite subcortical lucency is noted. The left sacroiliac joint is also showing mild sclerosis. Right sacroiliac joint appears normal. I am looking at the pedicles. The pedicles of L5 vertebra predominantly on the left side. Uh, on the right side is not clearly visible, and there is mild sclerosis. No compression collapse of the evaluable vertebral bodies. I would like to see the lateral view of the patient to further comment on the pedicle. No associated soft tissue mass seen. And on lateral radiograph, I would like to zoom the image. Yes, I can see lytic lucency, which is involving the lower part of the sacrum and coccyx, and it is expansile, and it lies within the presacral space, and is causing its expansion and displacing the rectal gas girdle anteriorly. No further bony lesion is noted in the valuable skeleton. So I would like to ask the age of the patient. If it's a middle-aged patient, I would like to keep the possibility of sacral chordoma. This lesion is locally aggressive, so I will immediately inform my findings to the referring clinician. We'll send the patient to the sarcoma center for biopsy. We'll further continue the study for further diagnostic confirmation and for local regional invasion, MRI pelvis with contrast. And then after confirming the diagnosis, we'll refer the patient to the oncological or orthopedic multidisciplinary team for further management.
So what do you want to do next?
I would like to see the MR pelvis with contrast of the patient.
Okay, we have a stir image for this patient.
Yes, I can appreciate, as I already mentioned, there is a sacral, in the region of sacrum, there is purpley lucent lesion, and which is showing a lobulated margins, T2 stir hyperintense soft tissue noted in the anatomical site of the lower sacrum and coccyx, as the lesion is anteriorly displacing the rectum without definite rectal wall invasion. Seminal vesicles and evaluable bladder appear normal. I cannot appreciate any further signals in the rest of the valuable bone. So this is in keeping with the sacral chordoma.
Okay, and
I would also like to ask the post-contrast enhancement of the patient, and if the images are available, I will comment on that to further confirm.
What are you looking for on the post-contrast images?
I'm just confirming my diagnosis and looking for the post-contrast enhancement, as this is showing moderate post-contrast enhancement. This will show moderate post-contrast enhancement.
Yeah, okay, fine. I mean, many times okay, fine. So you are looking for contrast enhancement. Will it change your diagnosis?
Ma'am, I would like to keep the differentials, sacral chordoma on top, less likely possibility of, as there is no calcification, so the chondrosarcoma, low-grade chondrosarcoma is less likely. Third possibility can be sacral metastasis from some primary, if the patient is known of some primary. Yeah, these are my differentials.
So the next patient has come in with lower to groin pain. That was a presentation for this patient.
Lower groin pain. Okay, I'm provided with a plain.
Loin to groin pain. Loin to groin.
Okay, groin to groin. Okay, I'm provided with the plain CT abdomen of the patient, in which I can see a fat attenuation, mixed attenuation lesion having predominantly the fat content, noted in the right suprarenal region, which is having well-defined sharp borders, and there is non-visualization of the right adrenal gland. There is no intralesional calcification. The borders with the liver and the diaphragmatic crux are normal. Left adrenal gland is normal. IVC shows normal lumen. So I would like to see the post-contrast images of the patient to comment on enhancement, as I'm suspecting myelolipoma of the right suprarenal or adrenal gland. So this is post-contrast photovenous phase images of the patient. I would like to take the density of the peripheral small nodule, which is on the periphery of this lesion, as this is a small enhancing component within this myelolipoma. If the Hounsfield unit of this enhancing lesion is more than 15 to 20 Hounsfield unit, then this can be the solid component, which is quite suspicious for some small malignant change. Otherwise, the lesion is very, very well defined. So I will stick with the diagnosis of myelolipoma in right suprarenal gland. No further lesion is noted. Left adrenal, as I already mentioned, is normal.
Do you want to comment on that nodule that you're seeing?
Yes, the outer aspect of the lesion is showing along the border, along its lateral border with the liver. It is showing enhancement, which was not conspicuous on the plane images. I would like to see side by side both images to confidently comment on the enhancement. This is small enhancing component. Yeah, this is showing enhancement, as on plain images, this is not very conspicuous or well demarcated.
Okay, so what's your final diagnosis?
Myelolipoma with uh, low grade, uh, low grade sarcomatous nodule. Uh,
Myelolipoma with sarcomatous nodule, yeah?
I am I'm thinking, what should I put in the differentials? Mm,
Okay, so we'll move on
maybe
to
this
the
is what I
next.
can call right now.
So next patient is coming with like knee swelling.
Okay, I'm provided with a lateral view of the left knee joint, including the part of the femur and upper part of the tibia and fibula. I can see there is bowing deformity, anterior bowing deformity of the left femur, and there is moderate sclerosis along the anterior as well as posterior aspect of the femur, and there is small lucency noted within the mid diaphysis. Uh, no further bony lesion is noted in rest of the evaluable bone. So I would like to see the AP view of the patient to further confirm. On AP radiograph, there is, I would like to zoom the image. On AP radiograph, lucency is noted along both medial and lateral femoral condyles, uh, and there is some soft tissue which is noted in the posterior knee joint, and this is obscuring the left tibio-femoral joint compartment, and there is marked reduction in the joint space of the both femur and tibia, as well as in the tibiofibular joint as well. There is erosive changes noted in the joint with mild subarticular sclerosis, and I would like to ask if there is history of any chronic illness. So um, I'm thinking of the disease which is involving not both the bones and the joint as well. So this can be a case of uh, rheumatoid arthritis, but as I cannot appreciate any um, reduction in the bone density, so ma'am, I would like to ask the age of the patient.
Oh, it's 25.
So the second possibility, first possibility in this case can be the hemophilic arthropathy, which is involving the joint and causing the chronic changes. And second, less likely possibility of the juvenile rheumatoid arthritis, which is with my second differential. I would like to see the full extent of the femur as well to further comment on the sclerosis. And the bowing deformity is also favoring that there is some osteopenia as well. Uh, is there any previous imaging available for this patient?
The patient not only presented with left knee pain, but they also had left ankle pain, and they went on to have like an MR scan, to look at that. So, I mean, the way this is taken, you have in and out of phase, alternating. It wouldn't load as two different images. So that's why you have this, yeah? So this is equivalent to your stir image, yeah? And this is equivalent to your T1 weighted image.
Okay, I'm provided with in and out of phase images of the ankle joint in which there are lobulated um, hypo and hyperattenuating lesion, which are noted in the tibio-talar joint space, and there is destruction and marrow signal abnormality involving the tibia, and reduction in the joint space is noted as well. Thus, these lobular projections are also noted involving the calcaneal talar joint space as well. I'm thinking of some synovial. Mm, I'm still thinking of some hemophilic pseudotumor, and these are the intra-osseous hemophilic tumor, which are causing secondary degenerative changes.
Okay, so that's your diagnosis in hemophiliac lesions.
Excuse
Yeah.
me,
Yes, yes.
10 minutes left. 20 minutes have gone. Thank you.
Okay. So we're on to actually, the last case. Uh, so this patient is presented with swelling in the neck, a lump in the neck or swelling in the neck. Yeah.
Okay. I am provided with a CT chest in the arterial phase, and I'm looking, yes, there is a moderate to markedly enhancing mass, which is noted in the right, which is noted in the anatomical site of the right internal carotid and common carotid artery uh, uh, in between the carotid bifurcation, which is showing multiple intralesional enhancing multiple intralesional dilated vessels and flowoids, not flowoids, enhancing vessels in the lesion, and uh, yes, this is completely encircling and causing displacement and uh, yes, displacement of the carotid vessels, no definite vascular invasion, and there is mild circumferential narrowing of the lumen of the right common carotid and internal carotid artery. As this lesion is moderately enhancing and is located in the carotid sheath, so I am having the differentials of paraganglioma and schwannoma as my top differentials. I would like to see the plain images of the patient as well, and there is no extension to the parapharyngeal space. The parotid gland appears normal, no extension into the spinal canal. The vertebral arteries on both sides appear normal. The contralateral side appear unremarkable. So in this case, paraganglioma is my top differential. Second possibility is schwannoma of the vagus nerve. I would inform my findings to the referring clinician and will refer the patient to the vascular surgeon, as these lesions are highly vascular. So the embolization is required in these cases for in the for the surgical planning and to downsize the tumor.
Is
So
there
the
anything
final
else
is
you want to
26
look
cm.
at?
Sorry.
Is there anything else you want to look or do?
I'm looking at the adjacent structures. Um, would you please scroll a little bit? Um, I want to look at adjacent structures as well. Mm, the
So the patient also
then
had
the
an MR scan.
okay. The lesion is bright on uh, star images. This is ma'am post contrast T1 part set images, and the lesion is showing moderate enhancement. Yeah, these are star images, and the lesion is showing moderate enhancement with multiple internal forward. So carotid body tumor can also be a possibility, as this is playing the both vessels. Um, yes, this is all I have in my mind.
Okay, fine. Thank you. I think we're done cases. Yes, we have. So I think you have still about 3 minutes or 4 minutes. So, but it's done and you stop. Yeah.
Yeah.
So thank you for that, and I will go through the feedback now. So yeah, it's what I was trying to show you was, the fact that the bifurcation is splayed. It's the typical site for glomus tumor. So, and I think you got that on the first one, but it does extend to the parapharyngeal space. So they may want to, just make sure that your spaces in that region, because head and neck MR is also part of core curriculum. So just make sure that you know the spaces in that region and you're able to describe the lesion well. That'll be the only feedback. But you got the diagnosis. It is glomus tumor of the carotid, and it's exactly at the bifurcation that you get it. It is hypervascular. You saw on the CT scan, and you can see the how it's placed there. Yeah.
Yes.
So that's the bifurcation, and it's playing exactly in that way. Okay. Good. So that's that case. The previous one was yeah. So why do you think this is happening?
Due to bone softening, maybe. I am not able to figure out.
So your main, I think, differential was I mean, you were sort of getting juvenile rheumatoid arthritis, but you said hemophilia, yeah.
Yes.
So I mean that the notching, you can see the notch is really big, yeah. And what happens is, because of the repeated insult due to the hemarthrosis, the epiphysis fuses, yeah, and therefore one limb is much shorter than the other, because the patient in the right limb didn't have many of these changes, and then therefore you start getting bending of the femur because of the growth spurt still on. The femur is growing, but this is stopped to grow, so that it starts bending over. So one of the features of hemophiliac, patient will be sometimes limb length discrepancy because of these features. Yeah, and it's because in the growing phase, the physis fuses earlier, and the bone is not able to grow, so it starts bending over, and there's also demineralization because of the hemophiliac. And this is like a typical example of those again, like pseudotumors you get because of the repeated hemophilic. Okay, so good on that, but that's the reason for the bending leg. So I thought, okay, it's not very common, but it can be seen. The next one was chordoma. So you did very well there. Many people will miss this. Okay, so the only thing I would say is you said sacrum. Sacrococcygeal is what I mean to be very correct. It's the coccygeal segments more than actual the full sacrum. That's gone. But absolutely right about chordoma. Local recurrence is very high. Okay, it sometimes distal metastasis is very rare, but you can get lung lesions at times. But local recurrence is very risky. So this patient we have had for we've been following it up, and I think 3 recurrences. So very good on chordoma there. This one. So this lesion, because it's not showing complete suppression on the stir images, that means it doesn't have just fat. It's well defined. So a liposarcoma, or in extremity, you don't call it a liposarcoma, you call it an apical lipomatous tumor, okay, ALT. So that is equivalent to your liposarcoma that you would have anywhere else. So ALT will have heterogeneous signal intensity. So what I was trying to get is, because your description that it is well defined, therefore it is benign, is not actually correct. Although there is another entity. I think you were trying to say myelolipoma or something like that. There's another entity called spindle cell lipoma, which is typical in this space, the nuchal part of the neck, the back of the neck, and that can have heterogeneous cellular intensity. Okay? But for the purposes of the Viva, they would expect you to pick up the fact that this is not showing complete suppression, and therefore it is atypical, and it's not a simple lipoma. The differential can be a spindle cell lipoma, but we will proceed to do a biopsy. Does it make sense?
Yeah.
Yeah. So spindle cell lipoma is the word that you were looking for, I think, because you did talk about the thing. So well done on that as well. But that will be the only caveat I would say. It's not that just because it's well defined, it's not ALD. Yeah.
Okay.
The next one, you got it, and then you said about the post contrast. So let me just show you the post contrast. So the post contrast, if you see, that's why I was going up and down for you to look at it. It's just a blood vessel.
Okay. Okay.
Yeah. Can you see? I mean, that's why I went on.
Yeah.
I did that a few times to show you, like. So it's just a blood. It's not a nodule. So
Okay.
the answer is still what you said, and it is still an adrenal myelolipoma. Yeah.
Okay.
But
Yeah.
that's just like a vessel. See.
Okay.
Yeah. So well done for getting that myelolipoma. And what was the first case? Oh yeah, and this one also. You went for brown tumor, but remember, for the brown tumor, the mineralization is absolutely normal. Yeah. And there are no other features. So, but you redeemed yourself after you saw the MR, and you said, oh, they're all cortically based and they're well defined. And you also picked up, the third lesion here. And the syndrome is Jaffe-Campesini syndrome. Like, when you have a cephaloid spots and neurofibromatosis type 1 kind of a thing can be associated with it. Yeah. But very well done. I mean, so just be a little bit like you're doing very well with, you described it, you immediately saw it because many people struggle to see it. And then it was like cortical based, that's the other thing. Because I think the candidate number 2, I think, had the brown tumor. So they said, oh, but it looked eccentric. In her case, it wasn't eccentric. It was there. It looked, from there, it looked as if eccentric. But this is definitely cortical based. Yeah. So for brown tumor, not a good this one. But I think what you were trying to do was think of benign multiple lesions. I think that's what you were going for. Right? Yeah.
Yes.
So yeah, and it's not very common. How many have you seen multiple NOF?
Yeah.
Yeah. Okay,
Very
but
good.
very good. And you stuck to it, and though you've not seen it before, I say an elephant is an elephant, whether on land or on water. So if it looks like an NOF, it is an NOF. Yeah. How many ever they are, and wherever they are. Okay. So very well done. All the cases. So you got the diagnosis. My main take-home message for you will be little bit. You can slow down, just a little bit, and you'll pick up more points. So well done.
Yeah. Thank you, ma'am.
Fine. I think I'm seeing some questions. So anybody explain teaching point, neck lipoma? Neck lipoma, that is a typical site for a spindle cell lipoma. And main thing is to appreciate the signal intensity on the MR. The last answer was multiple NOF, and that is non-ossifying fibromas. And it can be associated with a syndrome called a Jaffe-Campesini syndrome, which is if the patient has cephaloid spots, skin lesions, and neurofibromatosis. the board bone, what is it? So that's what we're talking about, hemophilia causing growth disturbances.
So, Priya, one question from my side,
Yeah,
which quite a few students have asked me. Now, in the current format, each examiner will show them 3 cases plus 3 cases means 6 cases in the 30-minute Viva, which is what
yeah.
we did today. Now, between the lines, if all cases are sort of going to be of equal length, should I say, duration-wise, so we are expecting multi-modality cases, all of them, or is there a set hard and fast rule? Or, for example, complex CT, a simple CT can also take 5 minutes. So what are your comments about this?
No, I don't think. I mean, it will not be like everything will have three, you know, modalities, or everything will be, having uh, uh, multiple imaging. So I think it will vary, so that they will have some which are still like warm-up cases we used to call, in the old Viva. So you will have a range. It won't be like complex, complex, complex. It will be simple, intermediate, difficult. Yeah. Again, intermediate. You know. So some combination like that. It won't be all simple, or all intermediate, or all difficult. So there will be all three categories amongst the six.
Right. And so between the line, if an examiner has got 15 minutes, they will select cases which can be reasonably done in 15 minutes, but one case might be a slightly less
Yeah,
complex.
yeah,
The
yeah,
other one might take seven
yeah,
minutes. This one might take 3 minutes. You know,
yeah,
that kind of thing.
yeah. Like very typically, like your last candidate three, she finished all the six, and she had 3 or 4 minutes to spare.
Yeah.
That's fine. Like it's like even in interviews, we have some candidates who just answer all the questions. Done then. They don't need to be punished for being good. So it's done. So I think, but only thing is you can't go back to any cases. I think somebody asked, can you go back to something that you want to go back and say, oh, can I go to case one now or something? You're done the case, you move on to the second case, move on. That's it. So.
Uh,
But you're right. It won't be like all difficult, all this one. There will be variation amongst the six.
Yeah. So you have already answered this, but I'm elaborating because many people have asked me this. So for the audience, once again, we used to call classical warm-up cases, for example, a chest X-ray with a loser zone in the scapula is a classical, warm-up case. So it can still come, isn't it?
Yeah, it can still come. I mean, you can
Yeah.
still have the category. But I've also seen, Dr. Khan, what do you think is a warm up? People will struggle with that.
Yeah, exactly, because they will go into, yeah, they won't pick it up and they will take
And they will
five
start
minutes.
talking about something else, and you're trying to weave them down. Then they spend more time. So examiners will manage the time, with the candidate. But the candidate, what I was trying to emphasize was the candidate also needs to understand if the examiner is trying to say let's go to the next case. That's because you have to see all six cases. So it's the joint responsibility of the candidate examiner to see all six cases.
Right. There was a question about communication. If you can read that and answer that.
I saw one, and how to prepare for new short case segments. I would
No,
say,
excuse me, not this one, but there
uh,
was another question which I'll read for you.
yeah,
Is there marking for communication skills of a candidate question mark? They are talking about your description, your presentation, your language skills, your vocabulary. Will you be penalized for that? Over to you.
no, I mean, what they mean by communication is, are you giving me a rational explanation of what your findings are? and why you think those findings are, and what will you communicate with the clinical team about what you will do next. So that's what we're looking for. So that's why I was trying to emphasize to somebody else as well, saying don't jump to a diagnosis, because I want to know how you came to the diagnosis. Do you have a methodical way of approaching it, and then communicating your findings, with describing it, and then coming to a conclusion and sharing the management plan. So communication is the whole thing. It's a holistic thing that they are looking at, and it will be done throughout for all cases. It's not like you're doing for, oh, let's see whether this communication for this case was, how was it. And I don't think it's the vocabulary will be, what are the words you use. Like, I have seen candidates in other Viva practice, where they state all the aggressive features and then they'll come with a benign diagnosis, which is how, what are you communicating on your report? You can't say that there's an aggressive periosteal reaction, there's a wide zone of transition, and I think the diagnosis is non-ossifying fibroma. It doesn't make sense. That's because the surgeon will say you are describing a aggressive lesion, you are giving a benign diagnosis. So I think communication is part of the whole thing. Your interpretation, your management, your conclusion, and what you are projecting to the examiner. New humerus tight on long as equal marks for long as short, but only 6 cases for long, so less chances to redeem if short cases, so easier to make up the marks. I think the long cases format is what it has been, so it's the same. It's not changed. But they have changed is, how they used to mark between 4 and 8. That's what they used to mark. They have now changed it to 0 to 5. So, it's more logical, the way you think about what the marks are. So I don't think they have changed that. And the short cases is in-depth analysis of the plain films. So, you need more cases to do that analysis, and also the opportunity for candidates to show their plain film skills.
Right. So if you can give us your parting comments, please.
Yes, I think this forum is really helpful, and hats off to you, Dr. Khan, for making this such a fantastic platform.